there's really no one single leadership style that I follow to the hilt every time. It's going to depend on the situation, the people that you work with, and the demands of the situation. So, for example, if you're dealing with much more senior medical technologists in the lab, like what you've had before when I was in training, and I tend to just be very supportive. I explain to them what needs to be done, and then I ask them like, how do we go about it? Because I cannot just step in and tell them what to do, because they already know what to do and they know how to do it better. But in some cases, like when I have to deal with medtechs that are new or who are trainees or having their postgrad, then I will be more hands-on with what is with I would be more less managing and more instructive with what to do. So it will depend on the setting, like and the people that you work with.
So in regards to that, Doc, how do you evaluate the team performance?
Specifically where? Sa lab? Or
Inside the laboratory, sir.
Sa lab, it's important that we have key metrics. Well, not just with the labs, but anywhere you work in general, because these metrics guide you on what you wish to achieve. Diba? So, it's these metrics. It's important that we have a way to gauge how we are doing, and we use these metrics to determine if we're on the right path. So, for example, in the laboratory, what would be the key metrics? Number one, of course, is turnaround time. So we have to ensure that the turnaround time is being met, and we also have to ensure that the turnaround time fits for each particular test. You cannot just give a catch-all metric, like for example, turnaround time of 4 hours, because these tests are different. Like for example, the turnaround time for potassium or troponin will be different, for example, compared to the turnaround time of fecalysis, because the results that you get will be some results that you get are more urgent compared to others, right? So that's what another would be the accuracy of the results that you give. Okay, you have to ensure that the results that you give are accurate and precise, and to do that you have to do very meticulous monitoring of your quality control. So for evaluating performance, you go back to the metrics. What are the things that you're trying to achieve? Okay?
So how do you manage or handle incident reports inside the laboratory?
Whether in the lab or in the faculty or in the college, all incident reports must be documented. Okay, everything must be documented. Everything must be formalized. There is a lot of pushback sometimes because people tend to associate formality and documentation with bureaucracy. It's slower, but to ensure fairness, to ensure that everything, all protocols are followed insofar as decisions regarding hiring and retention of employees are followed, then we have to make sure that everything is written down, everything has a documentation to back it up. For example, if there are complaints, even at your level with the students, I always ask, can you send an incident report for this? Because we cannot just say that this person said this and that, right? And after that, I call them in. We call in 2 more faculty as part of the investigative committee, and then we write down everything that was discussed. We explain where in the manual are the violations and the corresponding penalties, and then we write things down, like what are the penalties that will be given to the student and who was in attendance. We document everything.
So do you categorize yourself either as a leader or a manager, and why?
Both, I think. And again, there's no clear cut. Delineation, and there should be no clear cut delineation, because a manager will have to deal with the day-to-day activities, and as a leader, you need to have an idea of where your organization is going after a certain period of time. So, if if you just think of yourself as a manager, then basically you will have no direction for either your lab or for the college, because there's no path for improvement. And if you just think of yourself as a leader, then that's going to be like having someone with his head up high up in the clouds. You're just looking for you're just thinking of something aspirational, but you do not have the execution. Okay, so the two must work hand in hand.
So, in what ways are you implementing to keep the good employees from the bad?
Keep in terms of retention, like retaining the good employees. I think it's equally important to recognize good effort and good output, just as well as identifying the bad behavior or the bad practices. So it's important that you do not just call out inappropriate behavior or poor output, but you also recognize the good efforts of the team. And sometimes that's the part that can easily get lost when you have a lot of problems in the organization. It's so easy to fall into the trap of calling out, this is wrong, this is wrong, this is wrong, this is why we're having problems. But it's usually the good people who are left out in the background because you don't have to think about them at all. So it's important that you recognize the efforts. Periodically, we always recognize this is what we did right for this semester, or for this month. We're producing more income for the laboratory, and that's because of chemistry, because we have our IC chemistry tests that are being ordered.
So, are you participating in external quality control like accreditation, NECAS or ECAS from RITM or
Yes.
any similar activities?
Any lab should be participating in ECAS and ECAS, depending on the section. It's going to be RITM, some would be in the from Center and KPI. It depends on what section. For example, in HEMA, this would be in KPI. Okay, so some I know will be in East Ave. Okay, so any lab, especially tertiary labs like SUMC, will always have participation in ECAS and ECAS. In terms of the college, we also have external quality assurance, and that will fall under ASCO and CHED, with regular monitoring that we follow their rules and guidelines.
And for number 7, how important is quality control in the laboratory setting?
It's very important, and you shouldn't be running a lab if you don't have QC or if you don't have understanding of any form of QC. All the results, it's so easy to fall into the trap of thinking of our specimens and results as just numbers, because we do not see the patients. But these numbers that we generate are reflective of the health of our patients, the status of our patients, and will dictate the management of the surgeons and the clinicians. So to ensure that the results that we are giving out are reflective of the true status of the patients that will guide the management, we need to have a very strict QC program, a very strict QC protocol.
So, what are the most common laboratory incidents that you have encountered inside the laboratory?
This is consistent naman with what we know, but most of the insofar as operations are concerned, the most common problems would be pre-analytic errors. So pre-analytic errors would include billing problems, wrong use of the tests, wrong requests of the tests that are being requested by clinicians, because in as much as clinicians do not have, in as much as clinicians are trained for these tests, the exposure to laboratory medicine is much more limited. So you will expect some degree of miscommunication with what the lab knows, or some degree of gap between what the laboratorians know and what the clinicians know. And this is important because medtechs, even on their end, should know already the technicalities so that they can advise the doctor. Okay, it's a multidisciplinary team. You don't answer directly to the doctor. Okay.
So how do you balance effective leadership with maintaining positive relationships among laboratory employees, Doc?
It's very, very difficult. It's very, very difficult when you're placing a leadership leadership position because you have to ensure that business or work is separate from personal affairs, and that's very hard to do because we are people and people get hurt by bad feedback, and it's for us, like when we are in positions of leadership, sometimes you will have to give negative feedback, and the purpose is for improvement. And I think one of the ways that we do that is to create a separation between work and personal affairs. We can all be friends. We don't have to, but we can all be friends at work. But then again, what is work? Your output in work will be judged as that. Okay? Not because you're friends with the people that you work with.
How does a pathologist's leadership role within the healthcare team contribute to improving patient care and outcomes, particularly in the context of diagnosing disease and guiding treatment decisions?
This is a very good question, and this is a very good question, and this is something that can be a bit nebulous, especially in some areas or some hospitals where you rarely see the pathologist. There are a lot of med techs who don't really know what the pathologist is for, and there are also clinicians who do not know what the pathologist is there for. They have their own thing. They request for their own tests without guidance, seeking guidance from the diagnosticians. But pathologists serve as the link between the laboratorians, which are the medical technologists, or the people who work at the lab, and the clinicians who treat and directly manage the patients. We did not directly treat or manage the patient. We diagnose the patients. And pathologists serve to bridge the technicalities that the medtechs know. Like, for example, when you run the procedures for the different tests, we bridge that to the knowledge about diseases. Like, when you have a result of, let's say, 125 for a glucose test, for a fasting blood sugar, given that number, do we tell the clinician, yes, your patient is sick? Or do we tell them, wait, back off, I need to look at how the patient is, what are the factors that can influence the technical part? So we sort of bridge the technical that the clinicians do not know, and the technical that you guys do, and the medical that you guys do not necessarily know, right? And we provide background. Like, for example, when you give results that are this way, sometimes the pathologist would ask for deeper investigation into how things are being done, or we ask to get more information, because if you give out those results and it may not be reflective, the results can be correct, but it may not necessarily be reflective of the state of the patient. Like, for example, WBC count of 12,000. How would you guys think of that result?
Second year.
Second year. Okay, WBC count, that's elevated.
The infection.
Infection, we think that, diba? But for us as pathologists, since we have a deeper knowledge of, since we are medical doctors, we try to ask things. Is the patient symptomatic? Is there fever? Is there cough? Nothing. Okay, so what then do we ask? What time was the specimen being done? It was done 3 in the afternoon. Patient was a smoker, no active infection. So that explains your 12. Doesn't mean that the patient is sick. Because as pathologists, we know that WBC counts are elevated in the afternoon, and smoking can stimulate cortisol production, which will mobilize the WBCs. And that's what we do. We explain to the clinicians that this may not be a cause of concern. Okay?
So does a laboratory leader have to be a pathologist, no? If so, why?
By law, yes. By law, yes. And there is actually a movement which is worrying, because there is a movement among medical technologists to create specialists within medtechs. But the thing is, this goes back to what we keep on saying: these values, these results that we generate reflect the the status of the health of an individual. Now, if you take away the medical component and place just a medical technologist, the values will not mean anything. They will not have access to the body of knowledge that will supplement the repercussions of the results that will be generated by the laboratory. Sige, release lang na siya. Baka makasakto makadus. Sige, release. Di ba natang problema? Ilahan na may pangal. Pero, on the part of a pathologist, if a pathologist is there, you generate a result. We are going to ask, ay shucks, basig putla ni tiid. Basig pagpagastuon ang patient of 50,000 kay ang implication is na hidden cancer somewhere na wala nila na-identify. Kasi i-whole body MRI ni siya. Di ba? So, there you need to bridge the technical with the actual na medical of the patients, and that is what we are there for. We are the doctor's doctor, not pathologists. The doctor's doctor because we tell the doctor this is what you do because the results are here. Okay? So, for example, there, like when we read biopsies, when we read pap smears, some results may not be clear cut. For example, we had a case before. I was still a trainee then. I was a pathology resident. It was first year. There was a kid, age 4 years old, 5 years old, who had a very large belly, large stomach. They found out there was a tumor in the retroperitoneum, and it was compressing everything. It was compressing the kidneys, it was compressing the aorta. They took it out. They didn't take it out because the retroperitoneum is inaccessible. So what they did was they did a core needle biopsy, which is a long needle, you stick it to the patient, get small fragments, and it looked like a fatty tumor, and it looked really ugly. It looked really ugly, and initially the call was malignant na tumor, which is called a liposarcoma, which is a cancer of fat tissue. But for us as pathologists, we know that that is not common in that age. Sarcomas are usually found in elderly individuals. So what we did is we went back, we got more samples, we asked to get more samples. During the interim, because they could not wait for us, because remember, histopath takes a long time, okay, a couple of days. What they did is they started bombarding the patient with chemo. Right? But when we went through the slides, it turns out that it was actually a lipoblastoma, which is a benign tumor of fat. A lipoblast is an immature fat cell. So, over time, like you just debulk some of the tumor so it will not compress like the organs inside. Over time, it will mature into a lipoma, which is a very common benign tumor. I've heard of that, lipoma. But the implication there is because they could not wait for the pathologist, or they did not value what the pathologist said. They subjected the kid to chemo, and remember that the chemo, it affects actively dividing cells, actively dividing tissues, which you find in a growing kid. So essentially, what they did is they stunted the growth of the child. Right? So that is what pathologists do. We bridge the diagnostics with that management. We don't necessarily talk to patients, or we only see patients either when they've taken the organs out or when patients already dead in terms of autopsy. And then we provide the clinicians with a clear picture of what happened. This is why the patient died. This is why the patient had abnormal values. This is why the patient presented with this tumor. And we can explain up unto the genetic level why that happened. Okay? So that is what pathologists do. Okay?
Okay, Doc. That ends our interview, Doc.
Alright, sige. Good luck sa lab management din ha.
Yeah.
And
Yeah.
sila yung third year.
Oh my God, yeah, may
Ay,
parasite on histo.
dami para, no?
Yes,
Sa
sir.
cancel?
Yes, Doc.
Para and histo.
Yeah, see you guys.
Kung ano mo, ay, daghan pa ba nag-panic attack sa inyo ha? Sa first year, daghan pa man. Especially nga hindi ka face to face. Marag first time na face to face.